It's a pleasure to be here today. This is just really one narrow aspect of aortic aneurysm endovascular therapy for these particular patients. I'd like to thank the organizers for the opportunity to participate. It's been really outstanding. I really want to compliment all the speakers. I learned a lot. I always can learn more every day. These are my disclosures. So when we look at industry-defined angulation of the aortic neck anatomy, you can see that the Medtronic Endurant and then the Cook Zenith devices, they require a less than 60% angulation for optimal results in their devices. When you look at the Ovation Endologics, they further look at the aortic neck length, and then they define a aortic neck length if it's greater than 10 millimeters, then they can have a up to 60-degree angle. But if it's less than 10 millimeters, then they say it needs to be within 45. You look at the Gore excluder conformable or even the standard excluder, and it again notes that if you use this device in an angulated neck greater than 60 degrees, you may have suboptimal performance. But we do know that if we stay within the IFU, we can get outstanding results shown here at the 14-year data for the Zenith device with 98% freedom from AAA rupture and good freedom from late reinterventions with good freedom from aneurysm sac growth in a long follow-up timeframe. And in 2011, Ali Aburama looked at clinical outcomes for hostile versus favorable aortic neck anatomies. They considered hostile neck anatomy to be a length of less than 10 millimeters, angle greater than 60 degrees, diameter of greater than 28 millimeters, presence of circumferential thrombus, calcification of the neck, or reverse taper. And they did note a perioperative complication rate that was more significant for those with hostile neck anatomy as defined. They required more intraoperative proximal cuff placements, particularly in reverse taper, those with short neck lengths and increased neck angulation. This study from Italy looked at the immediate 2-year outcomes for EVAR with on-label and off-label neck anatomies with different commercially available devices in 2 Italian vascular centers. They looked at 133 patients treated with standard EVAR in the presence of this, quote, off-label proximal neck anatomy, which is really like I've just defined previously. But they did find that they had technical success in all cases in both groups, no real difference in unplanned adjunctive procedures, no difference in perioperative endoleaks, reintervention, or stent graft migration rates, or AAA-related deaths. And ultimately, they looked at patients with 2 of these criteria or greater, and they did find that there was a significant difference if the patients had 2 or more of these factors with intraoperative requirements of intraoperative adjunctive procedures, presence of intraoperative endoleaks, all-cause mortality, and also this was with greater than 2 criteria the same. But they did conclude that it's acceptable in patients who are not good open candidates. And this group from Stanford in 2007 looked at their experience, and they really looked at 218 patients who had a defined hostile aortic neck anatomy, some of which had 46% had a greater than 60 degree angle neck. That's a typo there. And they did find that the non-IFU patients were more likely to be treated with a suprarenal fixation. I think that may have been their bias at the time, and more required placement of proximal cuffs. But they did feel that at that time, with those devices that were available to them, that it could be performed safely in high-risk patients with selective, careful use of the different devices. And many adjuncts for hostile neck anatomy have been proposed, such as long-term results published for aortic banding, the durability of a pre-deployment Palma stent or post-deployment after deployment of the stent graft to eliminate type 1 endoleak. The use of fibrin sealant has been published, as well as the use of endo anchors, which has already been discussed, and other people have used the kilt in EVAR for hostile neck anatomy. But others have looked at the impact of the proximal neck anatomy and short and midterm outcomes in this Italian EndoBoot registry looking at the Bolton Trio endograft. And they tried to determine that if in the presence of a hostile proximal neck, would that represent a risk factor for increased failure rates? And they looked at 3-year data, and ultimately they actually, with multivariate model, did not see a significant difference with that device. Similarly, 5-year outcomes were found using from the Encore registry looking at the Ovation device, and they found that with the risk-adjusted analysis, there was no association between hostile neck anatomy and 5-year type 1A endoleak. I do want to note that here they quote an angulation of greater than 45 degrees as being severe. The AorticFix endovascular stent graft was actually designed for this purpose, for tortuous aortic neck or iliac anatomy. I did use this device, and I did have a good result. But ultimately, despite reasonable outcomes with the Pythagoras trial and 5-year data, this is really no longer available in the United States for a variety of reasons. They did look at 218 patients, and I just want to point out that their highly angulated neck anatomy group were average 83 degrees, which is fairly significant. But they did find 5-year specific results with no type 1 or type 3 endoleaks in either group, and 5-year freedom from all-cause mortality, about 69%, but from aneurysm-related mortality was pretty good at 96%, and freedom from aneurysm rupture was 99%. Most recently, the Gore excluder conformable AAA endoprosthesis has been released. This includes an option for angulation control and the ability to reconstrain the proximal end for refined positioning, which is handy. A secondary sleeve will constrain the trunk body up to 70% so that you can make adjustments. And then this controlled delivery is really performed in 2 stages. And the device modification that was utilized from the original excluder included individualization of the anchors and stent rows, as well as the use of a temporary attachment fiber. Looking at the outcomes for the Gore C3 device, their midterm outcomes from the European data from the global registry showed that outside the IFU, these patients require significantly more all or device-related reinterventions, but this did not sustain a significantly or result in a significantly serious adverse event. When you look at the endovascular treatment of AAA, with 19 patients looking at this device, they looked at aortic neck angles that were ranging from 80 to 110 degrees with a length of 16 down to 10 millimeters. And they found a long-term survival of 100%, no ruptures, endograft migration, or deaths. So they felt that this had good short and midterm results. Others looked at 249 patients, comparing the traditional excluder to the C3 repositional system. And they really found that, interestingly, the proximal extension cuff for type 1A endoleaks was needed more often in patients with unfavorable neck anatomy, but both devices provided good midterm clinical outcomes. So this study, although small, did not show a significant difference. Looking at the study to the right, using the Gore conformable, this study from Italy looked at 5 patients with severe neck angulation over 70 degrees. And I just mentioned this because they made some comments about technique. They suggested starting a little higher, because there's a higher likelihood that this is going to settle downward. Also, they more often employed an axillary to femoral through wire approach, and they felt that that may be advantageous. In addition, selecting the lowest renal to provide a marker for deployment. And this is just a case of mine, high-risk 90-year-old gentleman here. You could see is a very highly angulated aortic neck. This demonstrated actually a really very good result. I deployed this over a floppy wire for the neck. It did sit down. I did need to apply a proximal cuff, but I did get a good seal. And the only other thing I wanted to mention that I encountered in the case is when I went to do cannulation of the contralateral gate, it was really difficult due to the tortuosity, and I was unable to actually advance the limb. So I had to take it out and actually balloon that up, then to facilitate deployment. So it's hard to interpret. You have to have a lot of different skills to try to deploy these. This is the follow-up CTA for this patient. So the sac is stable, and as you've heard earlier, this may not really be a cure, but it looks for a 90-year-old, I think we're doing pretty good. This is a 74-year-old woman with a colostomy, high risk, 6 centimeter aneurysm, angulated neck anatomy, and lots of hardware, as you can see, which can affect your imaging. But she had a good result with the conformable Gore graft. And just this last case is a 72-year-old gentleman who had many aneurysms, and you can see here large AAA and bilateral common iliac artery aneurysms, a right popliteal artery aneurysm, found incidentally when he was getting a workup for his hip replacement. I was able to repair this device using bilateral iliac branch endoprostheses, and then the conformable endograft by Gore. And I just to throw back to Apostolos' recent talk, when I deployed the left side, I think I did actually deploy that a little low. I think it was going into one of the branches, and that did not stay open. So I would agree with his comment that it could portray poor patency down the road. So in conclusion, highly angulated neck anatomy continues to be a challenge for optimal treatment for these patients. There are different devices that have acceptable outcomes. in these patients who are high risk for open surgery. And I would say, again, open surgery may be a better option for some of these patients if they're good risks. And note that if there's 2 or more risk factors for hostile neck anatomy, they'll probably have a worse outcome. And we look forward to the results from the Gore highly angulated neck anatomy trial to see what those results will show. Thank you for your attention.